So I welcome you all for the second class of fungal infections. In last class we have covered dermatophytosis that included Tinea corporis, Tinea pedis, Tinea capitis. Now were left with Candidiasis. Uh, Candidiasis is also known as Candidosis or Moloniasis. Candida is an opportunistic fungus. More than 130 species are there in the nature, but the Candida albicans is the most common species we study, and it is an inhabitant of GIT, genitourinary tract, and skin. It causes various diseases involving mucous membrane, nail, skin. When mucous membranes are involved, it can cause oral candidiasis, vulvovaginitis, candidal balanoposthitis, and as far as skin is concerned, it causes intertriginous areas to be involved, and all the body folds they can be involved, and the axilla, groin, inguinal folds, perianal area, abdominal creases, submemory fold, interdigital, and nail folds can also be involved. Because these folds they have the skin friction is there, maceration of the skin is there, warmth is there, and more chances of penetration by the candida is there. So these are the area where the individual is predisposed to this infection, and warmth, moist, and maceration, it thrives candida species. Although we have discussed that Candida albicans is the main species which we study, but nowadays non-albicans species are also of interest, because multiple species are isolated, and there can be resistant to routine antifungals by these newer species. For example, if a patient of recurrent candidiasis or recalcitrant candidiasis is there, we should always think of Candida krusei, and which is resistant to azoles. So many patients on routine antifungals should be reconsidered for newer other treatment than of azoles. So there are other species like Candida krusei, Candida parapsorlosis, Candida tropicalis, Candida pseudotropicalis. Then how these Candida species they cause disease? If an individual has impaired immune response, that means if a patient is immunocompromised, then they are predisposed to Candida. And when adverse local conditions are also in favor of candidiasis, such as if there is reduction in competing flora on the skin by prolonged use of broad spectrum antibiotics, then there is overgrowth of candidal fungus, so causing candidiasis. Again, if pH of the area or involved skin or mucous membrane is high, that means it is alkaline, then it also promote growth of candida. Then use of diapers and occlusive undergarments also increases pH of the skin or mucous membranes, so it causes more growth of candida. There are other predisposing factors that as we have discussed, broad spectrum antibiotics. If prolonged use of antibiotic is there, then there is loss of beneficial bacterial flora which prevent overgrowth of candida. So then the use of antibiotics may predispose the individual to recurrent candidal infections. Then obesity, because folds are more occlusive, and there may be hyperhidrosis in obese people, and chances of candidiasis is more. Then diabetes mellitus, which is very important predisposing factor for candidiasis, and if it is uncontrolled, then chances of candidiasis is more. And sometimes individuals who were not yet diagnosed to be diabetic, they come to us with recurrent balanoposthitis or recurrent any kind of candidal infection. When we do fasting blood sugar, it is high, so they are diagnosed by presentation as recurrent candidal infection. Then pregnancy, again predisposed condition for candidiasis. Then individuals or females who are on oral contraceptive pills, they are also predisposed, and individuals who are engaged in wet work like cooks, housewives, and washermen, they are also predisposed to candidal infection. Again, immunocompromised state, it may be HIV or it may be some other cause of immunocompromised state, that may be organ transplant or the iatrogenic because of the drugs, immunosuppressive drugs, corticosteroids, methotrexate, cyclosporine, azathioprine, any kind of immunosuppressive drugs or anti-cancer drug, they can predispose the individual to candidal infection. When we talk about the clinical presentation of candidal infection, there are various presentations. We will discuss one by one. The first is oral thrush. Oral thrush can start as early as a newborn is there, and the newborn acquire this infection from mother during vaginal delivery. And healthy infants can also have candidiasis, oral candidiasis or oral thrush. Then when we talk about older children and adults who are on broad spectrum antibiotics for longer duration, or they are immunocompromised, or adults, they are elderly, or they are malnourished, then they are predisposed to candidal infection. When we talk about clinical presentation, there is grayish white membranous plaque on moist erythematous base and of the oral cavity, and including tongue. There is maceration, there is atrophy of papillae, and the tongue appear red and glazed, and saliva is not there. We all know that saliva inhibits the growth of candida, so any condition causing dryness of mouth predispose individual to candidal thrush. And sometimes we see elderly patients who wear dentures, then they are also more prone to candidal oral thrush because of poor oral hygiene, and there is less circulation of saliva in dentures. So these individuals, they are more prone to candidal infection, and there is chances of trauma because of oral dentures in these elderly patients. So more candidal thrush is there in these patients. In this slide, we see various presentations of oral candidiasis. It can be hypertrophic candidiasis, like in this picture we can see hypertrophic plaques are there on the oral cavity, especially on the tongue, and then over the lips along with tongue. In this we can see the palate is involved, curdy white membranous patch is there on the pharynx. Then atrophic type, where there is total loss of papillae and the tongue is red glazed without papillae, so it is atrophic type of oral candidiasis. This was another patient from our department who was HIV positive. You can see there is oral candidiasis. Again, tongue is red glazed. So oral candidiasis is common presentation of HIV patients. More than 90% of individuals who are HIV positive or who are patients of AIDS, they suffer with oral candidiasis or oral thrush. And again, he must be immunocompromised. Oral thrush is there, severe oral thrush is there. Then here we can see angular cheilitis also because of candida, along with oral involvement in the form of red glazed tongue. And in this picture we can see severe oral candidiasis involving palate. Then second presentation is angular cheilitis. This presents at soreness of the angle of mouth. There is maceration, there is transverse fissuring along with crusting in these fissures, and sometimes pinhead sized papules can appear in the surrounding, which are known as satellite lesions. As we always say that infections, they are usually unilateral, but sometimes they can be bilateral also, and secondary bacterial infection with staph aureus can be there. So when we treat these individuals, we should combine antibiotics along with mid-potent topical steroid to reduce the inflammation along with topical antifungal. Similar changes are also seen in various vitamin deficiencies like riboflavin deficiency and other nutritional deficiencies. So it is an important differential diagnosis of angular cheilitis due to candida or due to multivitamin deficiency. So we have to prove that which is the cause for this angular cheilitis. Another picture where unilateral angular cheilitis is there. A right labial commissure shows angular cheilitis, and in the second picture we can see bilateral presentation of angular cheilitis. Erythematous fissures are there at the angle of mouth. Again, we can see in this picture satellite lesions are also there. So this is a clue for candidal angular cheilitis. Then flexural candidiasis, as we have already discussed that there are predisposing conditions, predisposing body folds which cause candidal infection because of friction, because of retention of moisture or increased temperature. Then they presents as intertrigo. There is maceration there in the folds, and which leads to candidal overgrowth, and satellite lesions are there, erythematous lesions are there, and intense pruritus and pain can be there, and sometime diaper rash or napkin rash can present in infants or in newborns, and this has to be differentiated from diaper dermatitis. In diaper dermatitis, the flexors or the clefts are not involved, whereas there is no satellite lesions in diaper dermatitis, whereas in candidiasis there will be satellite small papular pinhead size small papular lesions which are characteristic of candidal infection, and we can confirm the diagnosis by doing the KOH preparation. So this is the differential diagnosis in intertrigo. Intertrigo can be of the body folds, or it can be in between the fingernails. So whenever a patient comes to us with intertrigo in between the fingernails or toenails, we should ask them to keep the parts dry, or as these individuals, they must be cook by profession, or housewife by as doing wet work. So our advice should be that they should keep their skin dry. So wetness increases predisposition to intertrigo. Then when nail folds are involved, and it can cause chronic paronychia. Wet work by cook, bakers, housewives, or patients with vulvovaginitis, they can have this chronic paronychia, where nail fold is painful, nail fold is swollen, and sometimes nail plate can also be involved, so that there is destruction of the nail float, and onychomycosis can subsequently be the clinical presentation. Sometimes post discharge can be there, the condition can be chronic, it can be recurrent, and sometimes when it is severely painful, then we should suspect superadded bacterial infection in these individuals. In this picture we can see a diaper rash because of candida. We can see these small satellite lesions. They are small papular lesions along with the main rash, so it gives us clue for candidiasis. So we have to treat this patient on topical antifungal creams, and we have to advise the parents that they should change the diaper as early as possible, and to avoid wetness because of the diaper. Wetness because of urine and because of fecal contamination, this wetness can predispose the child to candidal infection. Then this is a picture showing flexural candidiasis. Axillary area is involved with satellite lesions. The erythematous plaque is there with small pinhead-like papule along the borders. These are satellite lesions or daughter lesions. They are characteristic of candidiasis. Again, intertriginous area, submammary area is commonly involved. We can see satellite lesions, and this is intertrigo of fingernails, commonly seen in housewives or who are doing wet work. So these were two presentations. And now most common presentation in females, or that is 75% of women have candidal infection in some point of their life, and there is overgrowth of candida which causes severe itching and soreness of the vulval area with thick creamy white curdy discharge, although this discharge is not profuse, but it is so itchy, the condition is so itchy and soreness is so severe that it becomes so much discomfort to the patient. And labia is moist, erythematous, macerated. Sometimes the infection is also there in the cervix, and that is erythematous, swollen, eroded with vesicles on the surface. And predisposing factors for vulvovaginitis is pregnancy, again diabetes mellitus, that too uncontrolled, and degree of hyperglycemia predispose the patient to vulvovaginitis. And again prolonged use of antibiotics, that is broad spectrum antibiotics, if they are unnecessarily taken for longer duration, then the individual is predisposed to candidal infection because of loss of the competitive flora in the mucous membranes. So any female, the partner of these females, they can have a male partner, they can have candidal balanoposthitis, right? If a female presents with recurrent or resistant vulvovaginitis, we should think of Candida glabrata. As we have already discussed, it is azole resistant, so we have to give some amphotericin B, topical and amphotericin B for these individuals, so that they are relieved of their problem. Candida can precipitate psoriasis also. Some individuals who have inverse psoriasis where folds are involved, then Candida overgrows, and it can also precipitate primary disease of psoriasis. Then candidal vulvovaginitis is really agonizing for a female, and there is soreness, there is cardioid discharge, there is erythema, it is sometimes it is painful and intensely itchy, and profuse cardioid discharge is seen in these pictures. And again you can see candidal vulvovaginitis, cardioid discharge on erythematous mucous membranes. You can see involvement of the cervix also, erythematous cervix. Then in males, there can be candidal presentation in the form of balanoposthitis. Tiny erythematous papules on erythematous base of glans penis can be commonly seen after intercourse in those individuals whose partners are suffering from vulvovaginitis because of candida. There can be white pustules which can rupture, and there can be vesicular lesions also, and sometimes atypical radial fissuring can be there in this glans penis, and commonly seen in diabetics. And sometimes the patients coming to our OPD for these lesions, when we do fasting blood sugar in these individuals, they are that is very high. It may be up to 200 milligram. So the diagnosis of diabetes can be diagnosed by balanoposthitis itself. And in these patients, their partners, they have vulvovaginitis. And clinical manifestations, we can see the white patches on the membrane of the glans penis is often entirely become erythematous and erosive. In this picture we can clearly see the small papular lesions which are there on the erythematous area. Again, candidal balanoposthitis. Now if nail folds are involved along with nail plate, there is paronychia as well as onychomycosis. Again, this is a picture where nail fold is swollen and painful, and there is loss of cuticle, and the nail plate is also thickened, rough, yellowish, and here we can see destruction of the nail plate. So onychomycosis can be caused by Candida species. Then another agonizing condition for individuals, that is perianal candidiasis, or sometimes it present as pruritus ani in many individuals. There is intense itching in the perineal area with discomfort. The lesions are erythematous, macerated, with oozy area, with satellite lesions, which can be present, but they are not always there. So if these satellite lesions are there, they gives us a clue for candidal infection, so we should start the patients on oral antifungals as well as topical antifungals. And sometimes if we have some patients who are not responsive to antifungal treatment or anti-candidal treatment, there is a recurrence and there is no response, then we should always do the biopsy to rule out extra memory Paget's disease. Any abnormal skin because of some other disease like extra memory Paget's disease, there is increased candidal growth. So both the condition can be there, candidal overgrowth can be there, and some underlying that there may be some serious disease, that is extra memory Paget's disease. So we have to do biopsy in such cases. So it is really agonizing. In this picture we can see the satellite lesion in perianal dermatitis, so it must be candidal perianal dermatitis. So how to diagnose? We have discussed the clinical picture. Now how to establish the diagnosis of candidal infection? We can do the lab investigation by doing the KOH preparation. In KOH preparation, we see small yeast-like structures and budding yeast, pseudo budding yeast, and then if we do the culture, and then the routine culture is done of candida, can be done on blood agar also within 24 hours, which form staph-like colonies, and then fungal culture on SD media, which comes out to be positive in 48 to 72 hours. By doing the culture, we can further do the speciation of candida, so we can find out what is the exact cause. This is a bedside test, that is KOH preparation. In this we can see these yeast forms and pseudo hyphal form. So this is there, or this is the colony on Sabrodextrus agar. Histopathology is not routinely required, but if histopathology is done, then again we can see candida pseudo hyphae and candidal spores in histopathological section. Then how to treat the candidal infections? So the most important thing is to control the predisposing factor. We have to consult the patient to avoid predisposing factors. They have to be told that their hygiene should be proper. They should not wear tight occlusive synthetic undergarments. They should avoid hyperhidrosis, and if they are diabetic, they should control their diabetes. So all these if they do wet work, they should dry their hands and feet after their work, so skin should be dry. And if patient is immunocompromised, they should take proper treatment, or if unnecessarily antibiotics are taken, or if antibiotics are not indicated, then they should be stopped so that the candidal infection can be controlled. As far as treatment is concerned, we have topical therapy as well as oral therapy. In topical therapy, we give them topical clotrimazole, miconazole, ketoconazole, cycloproxamine, proxylamine, and sometimes we combine these topical antifungals with topical antibiotics when painful lesions are there, because skin infection because of staph can be there, so topical antibiotics can be combined. And sometimes, especially in oral angular cheilitis, when the condition is severely painful, patient is unable to open the mouth, we can add mid-potent topical steroid so that anti-inflammatory effect is there, and the resolution of lesion is fast, and patient becomes asymptomatic quickly. So sometimes topical steroids can also be added to antifungal preparations. When we talk about oral therapy, most commonly we give fluconazole, 150 milligram once a week. Sometimes it is sufficient, but if recurrences are there, then daily fluconazole can be given for a week or two, and sometimes itraconazole in 100 to 200 milligram per day for 1 to 2 weeks can be given. But if nail involvement and is there, then the therapy is prolonged. In fingernails, the therapy is for 2 to 3 months, and in toenails, it is 3 months and more. And sometimes pulse therapy is given, in which 1 week therapy on higher dose, 200 milligram BD of itraconazole for 1 week. Then there is no therapy for 3 weeks. Then again 1 week therapy. Then 3 week off, then 1 week therapy. This kind of pulse therapy is indicated in onychomycosis. Sometime older therapies like gentian violet, Castellani's pant, boric acid, they can be also beneficial, especially in resistant cases. And sometime if we give probiotics and yogurt, and it also decreases candidal colonization. So sometimes they can be beneficial also. Sometimes boric acid topically, and topical amphotericin B and flucytosine for recurrent infection due to Candida glabrata, which is azole resistant, is also beneficial. So we have to keep in mind resistance to azoles because of Candida glabrata. So this was all about candidiasis. So thank you very much.